Your immune system is designed to protect you, but what if it started attacking your blood instead? That's exactly what happens in ITP, and it can lead to unexplained bruising, internal bleeding, and even brain hemorrhages. Here's what's happening under the surface. Let's start with the basics. ITP is a disorder where your immune system mistakenly attacks your own platelets. Autoantibodies bind to platelets, tagging them for destruction. These antibody-coated platelets are then removed by macrophages, mainly in the spleen and liver. The result? A reduced number of circulating platelets, which increases the risk of bleeding. The ITP can be primary, meaning idiopathic with no identifiable cause, or secondary due to viral infections like HIV or hepatitis C, certain vaccines including MMR, VZV, and even COVID-19, medications, malignancies such as CLL and lymphomas, or autoimmune diseases like systemic lupus erythematosus. Symptoms range depending on the platelet count. Many patients with mild thrombocytopenia may feel completely fine, but when platelets count drops below 20,000 per microliter, spontaneous bleeding can occur. The symptoms typically include easy bruising, petechia and purpura, bleeding from gums or nose, heavy menstrual bleeding in women, bleeding in the GI tract, urinary tract, or even lungs. And in severe cases, CNS involvement such as headache, confusion, or seizures. Diagnosing ITP is a process of exclusion. Here's what we look for. Complete blood counts reveals isolated thrombocytopenia, typically below 150,000 per microliters. Coagulation studies are usually normal, though bleeding time might be prolonged. Peripheral blood smear can show large, immature platelets, a clue the bone marrow is trying to compensate. And because some infections can mimic ITP, we also screen for HIV and hepatitis C. A 42-year-old man visits his doctor complaining of easy bruising and bleeding from his gums. These symptoms began just yesterday. He also has a recent diagnosis of hepatitis C. On physical exam, there is no splenomegaly, but petechia are noted across the body. His platelet count is just 24,000 per microliters. The peripheral smear shows large platelets, consistent with increased platelet turnover. Based on this presentation, corticosteroids are started. The treatment for ITP depends on severity. If there is no active bleeding and platelet counts are moderately low, we may simply watch and wait. Many cases resolve spontaneously. The first-line treatment for active bleeding or very low platelets are corticosteroids, such as methylprednisolone. If steroids fail, or for quicker platelets recovery, IV immunoglobulins can be given. Second-line agents include rituximab, immunosuppressants like cyclosporin, and platelet transfusion if there is significant bleeding. Splenectomy is a last resort, reserved for chronic refractory cases, and patients need vaccines against pneumococcus, meningococcus, and Haemophilus influenza beforehand. Thankfully, most patients with ITP have a good prognosis, especially if a treatable cause is identified and managed. Some will relapse, but many recover fully with proper treatment and monitoring. To recap, ITP is an autoimmune condition where antibodies target platelets, leading to their destruction. Diagnosis is by exclusion, and treatment depends on severity. Remember to always consider infections and underlying causes like lupus or malignancy. If you found this breakdown helpful, be sure to like, subscribe, and hit the bell for more clear, concise medical videos like this one. See you next time.